Three criteria of judgment are of utmost importance in the evaluation of focal therapy. The priority is the control of the disease, then the probability to avoid a following radical treatment, and of course, the conservation of the best quality of life. The cancer control is the major issue in oncology. In all the phase 2 studies, in the targeted zone, the cancer disappeared in 80% of the cases and in almost 90% in the PCM201. In the study in Latin America, the efficacy was the same, even if more aggressive cancers were treated in this population. In the highest scientific level of evidence produced in the prostate photodynamic therapy field, again, the results were similar, whatever the localization of the lesion in the prostate. At 2 years, the risk of progression was twice as much with simple surveillance compared to prostate photodynamic therapy. At 5 years, the difference in cancer progression was maintained between the two groups. In total, regarding the major issue of cancer control, a minimally invasive physical treatment at midterm is superior to a simple surveillance. Does prostate photodynamic therapy reduce the necessity of conversion to a radical treatment? The answer is clear-cut. At 2 years, patients treated by prostate photodynamic therapy needed 5-fold less a radical treatment compared to a simple surveillance. At 4 years, the number of conversion to a radical treatment was divided by 2 between the two groups. If a radical prostatectomy was needed after a prostate photodynamic therapy, the surgery was feasible, efficient, and safe. Regarding the conservation of the quality of life and particularly the erectile function and the urinary continence, after a follow-up of 2 years, deterioration of the erectile function and of the urinary continence was the same in both groups, prostate photodynamic therapy and active surveillance. At 4 years follow-up, when including the conversion to radical treatments in both groups, the prostate photodynamic therapy patient had 37% less erectile dysfunction compared to the active surveillance group. As for urinary incontinence, the difference was even greater, with a reduction of 64% for the prostate photodynamic therapy group compared to active surveillance. In a modelization combining the PROTECT and the PCM301 studies at 5 years, regarding the erectile function, prostate photodynamic therapy was less damaging than a radical prostatectomy or even active surveillance, with respectively -79% and -31% patients with erectile dysfunction. Eventually, regarding urinary incontinence, the difference between prostate photodynamic therapy and active surveillance was 62% less, while reaching -88% compared to radical prostatectomy. Even if these last results are theoretical because based on the modelization, the trend regarding the conservation of quality of life when treated by prostate photodynamic therapy is still striking. In conclusion, regarding the cancer control, at midterm, prostate photodynamic therapy is superior to a simple surveillance. The risk of conversion to a radical treatment is significantly reduced with prostate photodynamic therapy. Eventually, the erectile function and the urinary continence are largely preserved with prostate photodynamic therapy.